Hello and welcome, fellow student doctors. Today we will discuss the Gunn pupil, also known as a relative afferent pupillary defect. Friends, I must say that it is not a question of if this will be tested, only when this will be tested. Commonly, it is presented in the context of a multiple sclerosis patient presenting with optic neuritis, one cause of a Gunn pupil. Don't you worry though, because by watching this video and hanging out with me, we will get you those points that you deserve on test day. Let's get started. To prepare you for test day, you will be able to 1. Explain the pupillary light reflex. 2. Describe the parasympathetic pathways responsible for pupillary constriction. 3. Be able to diagnose a Gunn pupil, that is a relative afferent pupillary defect, with a swinging flashlight test. And 4. Be able to list potential causes of this finding. To begin our discussion, let's briefly cover pupillary light reflexes, starting with the direct pupillary light reflex. This slide shows one eye with a brown iris and a black pupil. When light is shown into one eye, the iris contracts and the pupil constricts. This is a normal, direct pupillary light reflex, as constriction of the ipsilateral pupil occurred. That is, the pupil that was directly exposed to the light source. Now, to test the indirect pupillary light reflex, we need to look at the opposite eye's pupil. That is, the eye that is not directly exposed to the light source. So when light is shown directly into one eye, this causes constriction of both pupils. And so, in reference to the eye that was not directly exposed to the light source, this demonstrates a normal, indirect, consensual light reflex, which is constriction of the contralateral pupil. It is called an indirect consensual reflex because the pupil constricted despite not being directly exposed to the light source. As we saw on the last slide, when light is shown into this eye, it causes constriction of both pupils, demonstrating normal direct and indirect pupillary light reflexes. To demonstrate abnormal pupillary light reflexes, let's swing the light source over to the opposite eye. Now the pupils of both eyes demonstrate a relative dilation compared to the constriction that was just observed. Congrats, friends! We just diagnosed a Gunn pupil, which is a pupil that abnormally dilates to light, indicating an impaired direct pupillary light reflex. Additionally, the opposite eye demonstrated an impaired indirect consensual light reflex. This occurred because the eye that was directly exposed to the light source did not appropriately sense the light source. That is, a problem with the afferent light signaling or sensory light signaling pathway that triggers appropriate constriction of both eyes' pupils. Overall, the presence of a Gunn pupil indicates a relative afferent pupillary defect, which is impairment of both the direct and indirect pupillary light reflexes. Now, let's cover the anatomy of the iris as well as its autonomic control. Shown on the screen is an eye with a brown iris and a black pupil. The iris is composed of two main muscle layers, which are highlighted with a purple circle and yellow arrows. Note the purple and yellow muscles are part of the brown iris. I just made them a different color so we can discuss them more easily. So, the yellow muscle fibers represent the dilator pupillae muscle of the iris. These fibers are radially oriented and under control of the sympathetic nervous system. Since the dilator pupillae fibers are radially oriented, when they become activated by the sympathetic nervous system, they cause mydriasis, or pupillary dilation. Let the D in mydriasis stand for dilation, something that will be animated later. Moving along, the parasympathetic nervous system controls the iris sphincter pupillae, a circular muscle group shown here in purple. Since the sphincter pupillae muscle fibers are circular, upon parasympathetic activation, this muscle causes pupillary constriction, which is known as miosis. Let the lowercase o in miosis represent a pupil constricting. So, to activate the parasympathetic nervous system, light is shown into the eye. causing the sphincter pupillae to contract and cause constriction of the pupil. That is, miosis. However, if that light source is removed, this triggers the sympathetic nervous system and causes activation of the dilator pupillae to increase the size of the pupil to capture even more light. That is, mydriasis. With that background, let's walk through the parasympathetic pathway that causes miosis. Recall the muscle in the iris that causes parasympathetic mediated pupillary constriction is called the sphincter pupillae. In this diagram, all structures presented in a purple color operate mainly parasympathetic control, as we will see. So, when light is shown into either eye, the light signal is sensed by the retina and transmitted via cranial nerve 2, the optic nerve, to the midbrain, specifically the pretectal nuclei. Importantly, you must know that each optic nerve sends projections bilaterally to the pretectal nuclei. This occurs because optic nerve fibers projecting from each eye cross in the optic chiasm and then project bilaterally to the pretectal nuclei. With light signals from both eyes, the pretectal nuclei send projections to nearby midbrain structures known as the Edinger-Westphal nuclei. The Edinger-Westphal nuclei contain preganglionic parasympathetic neurons, and that is why the nucleus is in purple. I'll explain what preganglionic means in a little bit. Importantly, you must know that the pretectal nuclei, like cranial nerve 2, send projections bilaterally to the Edinger-Westphal nuclei, another important crossover in this pathway. From the Edinger-Westphal nuclei, preganglionic parasympathetic fibers hitch a ride on bilateral cranial nerve 3, oculomotor nerves, fibers to the ciliary ganglia. Of note, cranial nerve 3 is partially purple because it carries parasympathetic fibers, but cranial nerve 3 is only partially purple as it mainly contains motor fibers to control extraocular muscles. The ciliary ganglion is purple because it houses parasympathetic postganglionic neurons that synapse with the preganglionic parasympathetic fibers from the Edinger-Westphal nuclei. So, from the ciliary ganglia, short ciliary nerves project to the sphincter pupillae muscles of the iris. The short ciliary nerves are postganglionic nerve fibers from the ciliary ganglia that release acetylcholine onto muscarinic receptors found on the sphincter pupillae muscles of the irises. All of this signaling results in miosis, pupillary constriction of both eyes. Overall, there are a couple things I'd like to point out. First, it's important to know that short ciliary nerves specifically shorten or constrict the pupil. This is in comparison to the long ciliary nerves, which actually dilate the pupil, so make sure you know that it's the short ciliary nerves that shorten or constrict the pupil. Secondly, there are multiple crossovers in this pathway, as both cranial nerve 2 and pretectal nuclei send projections bilaterally. This is important because these crossovers explain the indirect consensual pupillary reflex, such that light shown directly into one eye causes constriction indirectly in the opposite eye. Now, let me show you normal direct and indirect light reflexes within this pathway. Here, however, light will only be shown into one eye. From this eye alone, the retina will sense the light and send afferent sensory signals via cranial nerve 2, the optic nerve, to the bilateral pretectal nuclei in the midbrain. From light being shown into one eye alone, these pretectal nuclei will send bilateral signals to the Edinger-Westphal nuclei. From light shown into one eye alone, bilateral Edinger-Westphal nuclei will send preganglionic parasympathetic nerve signals via bilateral cranial nerve 3s, oculomotor nerves, to bilateral ciliary ganglia. From light shown into this one eye alone, bilateral ciliary ganglia will send postganglionic parasympathetic fibers to bilateral sphincter pupillae muscles in the irises of both eyes, causing bilateral pupillary constriction. Overall, This demonstrates a normal direct light reflex as the pupil of the eye that was directly exposed to the light source constricted. Also, this demonstrates a normal indirect consensual light reflex as the pupil of the eye that was not directly shown light constricted as well. From this diagram, please appreciate how the crossovers via cranial nerve 2 and the pretectonuclei enabled the indirect consensual light reflex. Now, let me show you abnormal direct and indirect light reflexes within this diagram. This starts by swinging the light source to the other eye. If both pupils show relative dilation compared to the pupillary constriction that was just observed when light was shown into the other eye, this demonstrates a relative afferent pupillary defect. Commonly, this is due to a lesion in cranial nerve 2, the optic nerve of one eye. If damaged, the retina cannot send light signals via cranial nerve 2 to the rest of this pathway. This demonstrates an abnormal direct light reflex as the eye that had light directly shown into it dilated. This abnormal direct light reflex is called a Marcus-Gunn pupil. Moreover, this demonstrates an abnormal indirect light reflex as the pupil of the opposite eye failed to constrict because the crossovers in this pathway could not be engaged. Together, abnormal direct and indirect light reflexes constitute a relative afferent pupillary defect, abbreviated RAPD. Relative refers to the degree of pupillary dilation caused when light is shown into the affected eye relative to the pupillary constriction produced when light is shined into the normal eye. Recall that when light was shown into this eye, both eyes constricted. However, when light was shined into the affected eye, both eyes dilated. The degree of dilation is relative to the normal degree of constriction produced by light being shined into the unaffected eye. Afferent refers to sensory. As a refresher, afferent signals are sensory signals, while efferent signals are usually motor signals. A relative afferent pupillary defect is caused by lesions in the afferent, sensory pathway of light detection, such that light signals cannot be transmitted through a damaged cranial nerve 2. Additionally, if the retina is injured, such as from retinal detachment or macular degeneration, the afferent limb of the light reflex is again damaged. Overall, just know that cranial nerve 2 and the retina are the two key structures for afferent light signaling, and damage to either can result in an RAPD. Lastly, the pupillary defect refers to the abnormal dilation of the pupil of the affected eye when exposed to the light source. This is an abnormal direct light reflex in the affected eye, which is called a Marcus-Gunn pupil. Now, let's apply this material and diagnose a relative afferent pupillary defect with the swinging flashlight test, which is simply shining light into one eye, looking for direct and indirect light reflexes in both eyes, and then repeating this process in the other eye. Okay, student doctors, I will now play a series of animations. Watch the pupils and be able to diagnose which eye demonstrates a Marcus-Gunn pupil, that is, a relative afferent pupillary defect. So, what is your diagnosis, student doctor? This is the affected eye that demonstrates a Marcus-Gunn pupil. There is a defect in the afferent limb of the pupillary light reflex in this eye, causing relative dilation of both pupils. I have another question for you. What are the two key structures in the affected eye that may be damaged? The retina and optic nerve, cranial nerve 2, are the most commonly injured structures that result in an RAPD. These are the two key afferent limb structures, the light-sensing structures, of the pupillary light reflexes. Overall, the highest yield cause of an RAPD is optic neuritis in the setting of multiple sclerosis. Optic neuritis, that is cranial nerve 2 neuritis, presents as painful unilateral vision loss that can result in a Marcus Gunn pupil, and RAPD. Friends, remember this lecture on your school and board exams. I guarantee you that it will be tested, and it is usually in the setting of a multiple sclerosis patient presenting with unilateral optic neuritis. Time for a flash quiz. The question reads, a 34-year-old woman presents to clinic with unilateral, painful vision loss. The swinging flashlight test reveals constriction of both pupils when light is shined into the right eye. When light is shined into the left eye, both eyes dilate. The patient reports a history of similar attacks that were resolved with steroids. What MRI findings are characteristic of her underlying disease? A. Paraventricular plaques. B. Multiple punctate hemorrhages in the cerebrum. C. Multiple cortical and subcortical infarcts. Or D. Ventricular enlargement. The answer is A. Paraventricular plaques, which are characteristic of multiple sclerosis as shown in the MRI at the bottom of this slide. Since we diagnosed a RAPD on the previous slide, I wanted to show you how the boards test you on it. Either they directly ask you about the pathology and parasympathetic pathways affected in an RAPD, or they will combine it into a vignette about a multiple sclerosis patient and then ask you questions about multiple sclerosis. Overall, this multiple sclerosis patient is suffering from optic neuritis, which is causing the relative afferent pupillary defect, the Marcus Gunn pupil, that was discovered via the swinging flashlight test. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Understand that the iris controls the size of the pupil and is under parasympathetic control, which causes miosis or pupillary constriction via the sphincter pupillae, as well as sympathetic control, which causes mydriasis or pupillary dilation via the dilator pupillae. Understand that a Marcus Gunn pupil represents a relative afferent pupillary defect and is diagnosed with a swinging flashlight test, which demonstrates a loss of the direct and indirect pupillary light reflexes when light is shined into the affected eye. Understand that the indirect consensual pupillary light reflex is mediated via crossovers in the parasympathetic pathway, specifically the optic nerves and the pretectal nuclei that send bilateral projections. Know that retinal and optic nerve lesions result in afferent, that is, sensory, light processing defects, causing a loss of the direct and indirect pupillary light reflexes when light is shown into the affected eye. Lastly, know that the autoimmune destruction from multiple sclerosis of cranial nerve 2, the optic nerve, is referred to as optic neuritis and commonly presents as a painful unilateral loss of vision, which in turn causes a Marcus Gunn pupil, a relative afferent pupillary defect. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there is a great, big, beautiful tomorrow.